So if you'd like to be involved, so if you'd like to be included in the U21 pharmacy discipline group, do get in touch. So there should be a lead at every single university in U21 with the pharmacy discipline. So do try and get involved and keep in touch. Today we have two excellent speakers, Dr. Sarah Pontefract, Senior Lecturer in Clinical Pharmacy at the University of Birmingham, and Professor Kurt Wilson, who is Lead for Prescribing at the University of Manchester. And they're going to be talking about their ongoing work on a national system to implement electronic healthcare records in undergraduate education, which is going to be crucial in terms of ensuring the safety of medication in the UK healthcare system. And I think there's lessons to be learned for everyone as we move into a new electronic realm. It's been around a long while, but I think, as someone said once, the future is not homogeneously distributed. So without further ado, I'll hand you over to Sarah and Kurt to start their presentation.
Thank you, Anthony.
Sarah.
Do you want to share the slides, Kurt?
Oh yeah.
Good start. Thank you. Okay, so good morning everyone, and thank you for joining us for what we hope will be an interesting and useful session discussing our work on implementing the electronic health record into undergraduate education. So as Anthony has introduced me, I'm Dr. Sarah Pontefract, and I'm a lecturer here in Clinical Pharmacy and Therapeutics. My research interests have always focused around prescribing safety and how electronic health records can help to reduce errors. But also I'm interested in the unintended effects of the technology, for example, on staff workflow and communication between professionals. I'm just going to hand over to my colleague, Kurt, who will also introduce himself before we start.
My name is Kurt Wilson. I work at the University of Manchester, where I look after prescribing and medicine safety training for our course. We're the biggest course in the UK, so there are lots of students to train and to educate. And I also have to look after our final year of the course, so just before our graduates get in and cause lots of good or harm, depending on how things go with the patients that they encounter as junior doctors. So in terms of my background, I'm a GP part-time, a general practitioner, so a family doctor. In the past, I worked as a pharmacist before retraining in medicine. So I've got sort of a dual training background with some experience in clinical pharmacy as well. And again, like Sarah, I'm very interested in electronic health records, digital health, prescribing, electronic prescribing and the like. And I really think this is a gap in the education that we're providing for our students at the moment in the UK, and something that Sarah and I are keen to address and have made some good progress in addressing, I think, which hopefully we can share with you today. Sarah, do you want to go to the first slide? Next slide, yeah.
Okay, so the patient record has always obviously traditionally been paper-based, and aspects do remain on paper in some settings, particularly in the UK, where we're very mixed, especially in the hospital setting. Nearly all of our primary care settings are digitised, but only around half of hospitals are fully digital as it stands, although the pandemic has increased that slightly. Most healthcare programmes, though, still teach using paper records, so through the provision of extracts of notes and paper prescriptions, for example. This isn't necessarily because we're a bit out of date in terms of kind of the way in which we're teaching, but it's because of the challenges of moving to authentic digital alternatives to that record in the educational environment. But digital is the present. It's what students are seeing in practice. They aren't seeing the large volumes of paper records anymore, or very rarely. So today we're going to discuss how to address that disconnect between the classroom and experiential learning. And just to highlight really that it's important that we raise awareness that the implementation of the record isn't about ensuring students can use computers. The majority of undergraduates are incredibly digitally savvy, and more so than me. If the technology breaks when I'm trying to give a lecture, the first thing I do is call one of the students down to help. So the generation have high expectations of digital. They're particularly around digital and how it works together. So our students want everything to be interconnected and are often assuming that it is. And it comes as a surprise to many that the NHS isn't quite interconnected, and many healthcare records, for example, between our community settings and our hospital settings, aren't in interoperable communication at that interface of care. But as I said, it has got a little bit better during the pandemic. In healthcare, there are also a plethora of systems. So in primary and secondary care, so like our phones and being able to move from iPhone to Android, the learning around the technology needs to be quite system agnostic. What we're not wanting to do in this piece of work is teach students how to use one specific system. What we want is to be able to teach the skills and the principles around working with and alongside the patient record, so they can move from one system to another with training on how to use that specific system with the principles underpinning that. So it isn't about the use of computers, but it's the development of digital literacy. So Health Education England here in the NHS have defined digital literacy within healthcare, and it's defined within 5 domains. So digital literacy describes the competence in the safe, efficient access and use of the digital records. So it's not about being able to actually use the computer, it's around the whole use and the proficient use of that record. So current analysis has shown that there are gaps in the current provision that address more technical proficiencies in healthcare, but suppliers of electronic health records usually train a small section of the workforce. So for example, those people who are just about to start working, for example, in a new NHS trust, and they tend to be the people who are already part of the workforce. And so actually we're missing a large part of the future workforce in that training. We want to enable that the workforce are proficient in their understanding of the importance of the quality and accurate entry of data into the health record, and that capturing inaccurate and poor data could mean rubbish in and rubbish out. Communication and collaboration using and alongside the health record is essential, and it emphasises the importance of interprofessional education. So digital literacy is around being able to generate and access data, understanding the governance around the use of that data and the security, the confidentiality, if any consent issues are raised as part of that, and being able to work with others alongside that record as well. There are a lot of drivers for this work. Of course, like, Kurt and I are incredibly kind of keen to ensure that this happens. And because of our work in terms of prescribing, understanding prescribing record in practice. But there's nationally a lot of drivers for this to introduce digital into undergraduate and postgraduate education. So on a national level, UK policy is a big driver. So since 2014, with a 5-year forward view, it wanted interoperability to be able to start to reduce the gaps that we have in care and quality. Also, there was a large kind of policy about wanting to make the NHS digital by 2020. That did increase to 2023, but has more recently kind of going on to 2024, 25. So as much as the pandemic has really emphasised the need for digital, it did also delay a lot of implementation, particularly in the secondary care setting in hospital. But it's impossible really to have these policies to say that we want to be digital, because actually the current workforce needs to also be ready for that, as well as the coming in workforce, so our undergraduate students. So currently in the UK, there is this large body of work which is building a digital ready workforce. There are digital academies run across the country, and also with our chief clinical information officers regionally and also locally at sites, to ensure that people are developing that digital literacy. An independent review by Eric Topple also was conducted in the UK, that it advised really on how the technology is likely to change in the next 20 years to ensure safer and more productive, effective and personal care for patients, and what this then meant for education and training. So what that meant for us as the educators. So for example, the Topple review said that we must ensure that healthcare professionals understand the potential of digital health and that patient safety considerations, and that students gain the appropriate level of digital literacy from the outset of their study, so that they're exposed to these systems from the get-go, and that they understand exactly how that digital system can impact on their patient care, but also interact on them in the way in which they do their job, their workflow and their communication.
Thank you, Sarah, for some background there. I think, given that we work more and more within a digital landscape, Sarah and I quickly realised that we need to think about how to teach and train to help our future and health professionals that we look after at our institutions to contribute and collaborate in digital contexts. And we, as Sarah's pointed out, we could see that these contributions needed to be multi-professional, medics learning with medics, or pharmacists learning with pharmacists, etc., or interprofessional for that matter. And we needed to really respect and facilitate patient access and patient contributions to this process as well. So Sarah and I contacted colleagues from our academic networks and soon found that this interest was really shared across many institutions. And through further contact and discussion, we were pleased to find that companies from the commercial sector as well as NHS Digital and HE were also keen to collaborate and look at undergraduate education in this area. So Sarah and I established a national working group some years ago now to focus on teaching and learning supported by electronic health records. And at the moment, as it stands, we have 16 academic institutions as part of this collaborative group, as well as system suppliers. And we've gathered on a number of occasions to explore and develop teaching and education related to health. And one of the first tasks that our group realised we should tackle was to define some domains of skill and knowledge with associated competencies in order to provide scaffold for our teaching, our student learning, and in the longer term for formative and summative assessment, because these would be crucial as part of our measurement of our impact of education. These domains and competencies, these are domains and competencies that might be demonstrated within the classroom, but we also, or within simulated context, but we also wanted to make sure that they would translate into those which would be needed in clinical practice and in experiential learning for our students as they were on clinical placements and workplaces across the UK. So one of the elements that we thought about was digital literacy, as Sarah said, the proficient use of electronic health records and being adaptive to changes in this technology to really understand what it was all about. There are a number of competencies within each of our domains that we've put together, and I won't cover them all, but I'll give you some examples where we were trying to look at a measurable competency that could be assessed and taught against. So being able to explain how technology is a tool to facilitate clinical decision making, for example, would be an element of digital literacy that we wanted our undergraduates to come away with when they finished their courses. Accessing data is obviously very important. We access data all the time as clinicians to interpret the situation and to inform our clinical decisions. So, for example, being able to plan and review clinical care with reference to electronic data contained within an electronic health record would be an important competence for students to gain. Communication, again, we need to communicate effectively both with patients and with other healthcare professionals in the digital environment. So here's an example competence: maintaining patient engagement whilst using electronic healthcare records. So these competencies were put together and then subjected to an external Delphi review completed by clinical academics with relevant expertise, but outside of our collaboration, in order to refine and focus our work prior to publication. We were lucky enough to have these competencies published in an open access journal that was on the slide before. There were some other areas that we looked at, generating data, for example. So as well as being able to access data, you need to think about data that you generate and what that does in terms of, for example, the process of review and management of treatment. We needed to think about multidisciplinary working, how professionals work and interact together via electronic health records. So an understanding of roles and requirements from systems across professions was important for our students. And audit and help on monitoring, you need to be able to, for example, escalate concerns if you identify some problems within the electronic health record or the electronic healthcare record system. So lots of bits and bobs there to really help us with the first stage of our work as a collaborative group, and that was really to make sure we had these competencies there to guide our further work. Now it was time to think about how best to prepare our healthcare undergraduates for practice. we began to think about EHRs within our own work, because obviously I'm a GP, I work with electronic health records all the time, and the ways in which they might be best integrated, not into clinical care, but into education, including what, from a practical point of view, we would need to equip our students to deal with in order to be able to cope well with work within digital healthcare. And Sarah, I think you're just going to touch on now a little bit more about electronic health records and what they do and don't do.
Thank you. Okay, so the working group was a multidisciplinary team. And we had doctors, pharmacists, nurses, physiotherapists, dietitians. So it was a mix of people, and all of these people have worked a lot with electronic patient records or had worked a little with them. So understood when we were developing those domains of competency, the complexity of systems, but also some of the benefits and pitfalls that we see on a daily basis. So one of the first things was about intelligent technology. So such as the electronic health record, electronic prescribing, they tend to have clinical decision support, which can help the practitioner with their decision making and highlight potential safety risks to them. However, what's quite important is that students need to understand that the capability of systems is entirely dependent on the data and the accuracy of data that's generated in that system. So rubbish in, rubbish out analogy. Even when systems alert practitioners to guide practice, students need to know that the computers do not replace that sound clinical judgment. So if information is missed in the record, then information cannot be alerted and cannot provide guidance for the practitioner at the point of prescribing, for example. So they need to understand that the accuracy of data, so the generation of data, is really key to the system actually having that intelligence to work effectively. So students also need to understand the consequences of kind of the incomplete documentation. And this is something that can be easily simulated in a safe teaching environment, such as in a university interprofessional education session. So students can see the impact of emission errors, for example, and therefore how data needs to be complete in the record. So for example, simulating a record where the allergy has been omitted to be prescribed, and you create that scenario in the multidisciplinary team or interprofessional education setting, so that you're then requesting something is prescribed for a patient and you see exactly what happens in that scenario. And therefore the realization that actually the omission of the allergy information and finding that information in the record is really quite key, and checking that information is there. The same applies to comorbidities and weight and observations and other assessments that form part of that process that drives some of that decision making within the system. So it's all about building competency and doing that actually in a safe environment where you can omit information to demonstrate to students the importance of an accurate entry. Evidence has also shown that the electronic records can really impact on clinical reasoning and decision making. The practitioner is suddenly faced with all volumes of the previous paper record from which they need to build a patient story. And students and practitioners can feel overloaded with that information, and they're not really sure how far to look back to build that patient story in order to actually inform their decision making. So in terms of the information gathering competence, it's about needing to know what information is necessary for you to build that patient story and therefore inform care and make decisions about, with the patient about that care. Information overload can also occur as a result of over-alerting. So practitioners do feel when they're faced with these systems that actually some of the information is coming at them from all angles, with having to deal with alerts that are information only, but also alerts that they have to acknowledge, maybe with a password or a click or a rationale entry into why that alert is being ignored or has been taken account of. So unfortunately, though, with regards to that, we know that the fatigue of alerts can start to occur. So no two systems are the same either. So for example, if our students go on placement to a hospital setting and observe the record that has one system there, they move to another hospital with the same system, the level of alerting can be very different. And it's important that our students are aware of that fact so that they're not over-dependent on the technology when they move from one place to another if they've seen a lot of alerts in one system. And it's really important from a staff point of view when you consider the movement of staff, particularly for physicians in training. Technology also has unpredictable and unintended consequences. And this tends to happen much more with the implementation of technology and when there's a sudden change. But our students will be in workplaces where they will see that implementation and a change, whether it's an optimization of a system or whether it's a completely new technology that's added into the workflow. They need to know how that system could potentially impact on their workflow and their communication with others. So interprofessional electronic communication in systems is great. You know, you can be stood at either side of the hospital ward, for example, or completely different buildings and be communicating electronically with one another. That's really good from the point of view that you're no longer interrupting each other, but actually it can cause problems with regards to collaborative working, the coordination of care as well, and that development of team working. So again, it's about ensuring that students understand when it's okay to communicate electronically and that there shouldn't be this over-dependence on the system to facilitate that process. I'm now going to hand over to Kurt, who's going to talk a little bit more about the communication with patients alongside the patient record.
So yeah, this is a good opportunity to show maybe some of the unintended consequences of electronic health records and how they may encroach upon clinical care. And so this is an interest of mine, both in terms of the research reported elsewhere and from our own research we've conducted in Manchester. And it's really around analysis of the conversation that might take place in the presence of the electronic health record and how that might impact upon that. And as we are looking at a pharmacy group today, I'll focus on something on discussion around medicines and how medicines might be reviewed by doctors. So one striking example of communication within the context of electronic healthcare records is the way in which doctors may accommodate the data to support discussion with their patients. We know, classically patient notes, paper notes contain a lot of information, but the electronic health record displayed on a large monitor, or in my practice, several monitors. I've got 2 monitors in front of me with warnings and pop-ups and drop-downs and tick boxes. Can it be even more distracting for clinicians as they're trying to talk with patients? So I've selected a few clips from the data set we have in Manchester here, and these capture conversations about medicines listed in the patient's electronic health record between patients and GPs, with consent for the recording of the whole consultation by both parties, and demonstrate some pretty different ways in which health records is used within the discussion. And really what I want to bring your attention to is, are we looking at examples of communication being focused on the patient embodied, the patient in front of the doctor, or is the patient inscribed, the patient in the digital record, more of the focus of the consultation activity? As I say, there's lots of really interesting research around this area, going back quite a while, looking at Robertson when he looked at paper records, and more recently with electronic health. But I'll just show you a couple of clips. So in this example, the GP is seated in the larger chair on the right of the picture there. And she's paying close attention to the electronic record as part of her initial review of the patient's medicines. So let's just have a look what happens. So excuse the text and the way that I've displayed that there. That's just Jefferson notation that's used within conversation analysis, which is the method by which we analysed these consultations.
Just wanted to know chatting. Right, so try that. It's not on repeats, is it? No. I came to see you. Yeah.
So I think we could clearly see that the doctor's gaze is focused on the electronic health record. There's a break of 9.5 seconds from the patient's request to the doctor's acknowledgement of the request and turning to the record there, and then quite a delay and quite a sort of stuttering and interrupted consultation. Let's have a look at another example. So we'll go to this one now. So this is another doctor and a patient, again with consent, and this is an excerpt from their consultation where the doctor is reviewing some of the medicines with the patient. Again, the doctor's in the larger chair on the left-hand side of the picture there, focusing on the electronic health record.
Loperamide, pyridine, omeprazole, propranolol,
Yeah.
atorvastatin, ariprazole, tramadol. That's it.
Yeah.
And that small part of the conversation is actually followed by a very long break, 19 seconds, as the doctor then attended to the electronic health record rather than the patient embodied, sat there waiting. And we can see that the opportunities for response in that clip by the patient are quite constrained. Really, it's just yes, no, or a confirmatory role in that conversation, as the focus for the doctor is the patient inscribed in front of them there. So there were some examples of the EPR being used in another way, though, as a reference source, but not focus of the consultation. So let's just take another look at it might play again here. Just going. Okay, so here's another example. So in this example, again, the doctor's sat in the slightly bigger chair. Seems to be a theme there on the right, and the gentleman, the patient, is sat on the left of the consultation, and he's just come in to request some medicines.
So you're on the tertiary, and
Yeah.
I've just had a look at your notes. Actually, you've been on it for just over a year, haven't
Yeah.
you? How are you?
I think there we can see that the doctor has used the electronic health record to gain some data about the length of time over which the medicine has been prescribed, but the focus is clearly with the patient in front of her, the embodied patient, rather than the electronic record. And let's just see, in terms of constraint, with the other examples we've looked at, we looked at a constrained opportunity for patients to participate, where they were able to basically either confirm or refute the information within the electronic health record. What happens here, where a more open question style and open posture is used? So the doctor says, how are you?
Me, in myself, I've never been better.
Okay.
That's why I want to ask and see if I can stay on these.
Do you feel that they
I
really
think, because if I'm what I'm afraid of is if I come off them, I'll start dipping again.
Okay.
And it's happened before in the past.
So hopefully there we can see that the doctor has provided the patient with an opportunity to really expand on their concerns, the nature of their request. It's not simply that they want more medicines and that box can be ticked on the electronic health record, or that a prescription review box can be ticked. They've had a proper discussion, and she's actually provided an opportunity for the patient to reveal some of his concerns about stopping his antidepressant medicine and his previous experiences of what happened when he indeed did that. So I think this gives us another opportunity, another decision point in terms of how we train our undergraduates and what we want to do in terms of helping them communicate alongside electronic health records. We need to think about whether we are letting our students have observer-only access, which would allow them to gather information, to get some insight into digital health, but not have an obligation to add to records. Maybe that would be less distracting for them. Or are we looking at opportunities for our students to be able to access and to contribute to data within electronic records? This, again, could be good because it's more representative of the duties they'll have to carry out as qualified professionals. But then there's perhaps more worry around safety, about how care is contributed to, more potential for interruption and distraction. All of these things really need to be addressed. Sarah, I think you were going to talk about it from a tutor point of view.
Thank you. So from the kind of educational point of view, for the educator in that environment, so as Curtis said, many systems only really allow observer-only access. So when our students are out on placement, they can log in and review the record, but not actually contribute to that. This does mean, though, that students can gather the information, as Curtis said, and develop that clinical reasoning skills with access to a lot of that data. It also provides that general insight into it. And the observer-only access from the educator's point of view avoids errors from inexperienced or unsupervised trainees contributing to the record to influence patient care. So it's preventing any accidental contributions to the record that may cause a problem. In contrast, though, when our students go out onto placement and they're allowed to contribute to the record, that's actually contributing to the record with their own login as a student login. So that contribution would be very much controlled and set up in a certain way. So these allow undergraduates and postgraduates in training to contribute, allow data to be generated, which is great. That's a domain of competence we really want them to start to get used to doing. However, the contributions to care usually require or should require that validation by a clinical supervisor so that they are read and reviewed. And so, for example, should a student propose a medicine to be prescribed if they're in their final year of university, and that would need to be reviewed by the educator and authorised if that's an appropriate and accurate prescription for the patient. So this approach is beneficial. I have to say it doesn't exist everywhere and in every system. It's beneficial for developing the digital literacy in the generation of data. But the need for validation can cause delays, and it can also impact on the workload of the educator, and it can also impact on the workflow of others as well. So there is that kind of bearing in mind that the contribution to record does start to impact a bit more on the educator. There also is the risk that there's a duplication of effort. So, for example, in a hospital setting, if a trainee or a student proposes a prescription that has also been done at the same time on another computer by another member of the team, there is a potential for duplication there, which can all impact on patient safety. So there's this fine balance between allowing our students to have observer-only access, which is great for insight, or contribution to the record, which we wouldn't want them to do on a lot of levels, because that could then impact on safety from the interprofessional working point of view. So as educators then, when people ask us to add something to the curriculum, what we generally say, our response is that we have a very packed curriculum, and this all needs review to decide what can come in and what can go out. And we consider the necessity and the feasibility of adding something in. Hopefully, though, we've outlined the necessity of the patient record in education. And the feasibility then, the answer to that is that the electronic health record simply needs to replace the paper that we are currently using in educational sessions. So some underpinning lectures are required to deliver teaching, so about digital, such as the theory around information governance and information retrieval and consent in that record, for example. For teaching, though, we need a system to learn from that can simulate a real life record, and with IT that students can access, so that students can become digitally enabled for practice as well. So what we want then is to have a few lectures added in, which is about technology, but to replace that paper record, so the record just becomes weaved into curriculum with no major changes in the way in which we actually perform that teaching. All very well in theory.
Yeah, I was going to say all very well in theory, so thank you for that. So, yeah, I mean, so what we've got now, we've got our competencies, we've thought about our electronic records, it's all very well in theory, we'll just get on with it, yeah? So that's what we thought we'd do next in our working group. And so we thought, well, what's needed next? All that we needed to do was put some simulated records together, make sure that these records were ready for teaching. And so one of the things we thought about, well, they need to be authentic, don't they? They need to have some good sort of history in there. The language needs to be right. We need some patterns and trends, thinking about what we experience in our clinical work. There's lots of things that we see within these vast records. We need some noise, some distractions. So we convened again as a collaborative working group with our representatives from our universities in a large meeting area in the University of Manchester, and thought we'll get together and create a load of cases. It'll be easy. I wish that was true. We actually found the process of creation of simulated records was surprisingly time consuming. And even when we'd worked on these records together with input, as Sarah says, from different experts within our collaborative group, including our pharmacists, our nursing specialists, our doctors, etc., we still found that some of these case records we put together really, to be honest, lacked history and lacked authenticity when we compared them to what we would commonly see in terms of our clinical experience and the experiential learning that our students were receiving when out in clinical placements and experiencing real digital healthcare and seeing real data used within electronic health records as part of the experiential learning they were taking part in. In fact, I think we only managed to create in the end 4 clinical histories that we were reasonably happy with, and even these had some odd nuances within, such as one of the patients we decided had just changed country, so wouldn't have to have a lot of data from younger life within their record due to the move of nationality. So I think there's a lot of issues there around creating records for simulation or classroom teaching that are complete and authentic, so that you can help students learn about how to information gather and really help that data gathering to refine their clinical reasoning skills. And I think this is the most useful analogy you could think of. Really, what we'd ended up with were simulated records that didn't represent the true product. They lacked detail and nuance and were perhaps poor representations to start off with in terms of showing things to our students. There were some advantages. We could augment certain elements of the record. So we could say, look, electronic records are cut into these 4 phases. There's a top, a middle and a bottom, these kind of things. So they can help with some elements of training in terms of augmentation to get points across, etc. But they weren't the real deal. So what was needed next? Well, we thought, well, we need to refine our records and make sure that the history, the language, patterns and trends and noise and distractions, all the things that we encounter in clinical work needed to be improved. And I'll come on to how we think we should do that in a moment. But we also thought, actually, so we are going to let our students be able to access this data and contribute to it in a simulated teaching session, for example. So the other thing we needed to do was be able to use this data once and then be able to use it again for teaching. So this isn't clinical care. We'd have to get the electronic health record, use it on week 1 of the curriculum, and then maybe in the timetable we'd want to have another small group of students come along and go through exactly the same process again in terms of encountering a record at the same stage with the same set of information. And we quickly realized that through the sort of obligatory audit trails and storage of even deleted data within real electronic health records, that this would be a barrier to the reuse of clinical records in the way we'd want to for repeated teaching. So Sarah and I approached our collaborators from the commercial sector to see if we could address this point. So digital challenges or opportunities. We know we need to help our students rehearse, record, revisit. We knew that we wanted to have these records reusable so that we could have instance, comparative and longitudinal learning. We needed our records to be reusable so we could use them across interprofessional education, across locations, synchronously, asynchronously. We knew that some of our students would be within, for example, our medical school, but some of them would be distributed across all the clinical placements or different hospitals that they might go to, and there might be some remote learning. So, as I say, we approached our electronic healthcare providers, to see how we could address that. We thought, well, you know, we can't have real patient data, or can we? Maybe we need a system that can facilitate longitudinal learning where we actually use an electronic health care record and use some real patient data within. Quite a few asks then still. So first of all, we managed to get our commercial providers to develop and refine their systems for education so that you can put in a patient record and replicate it. And using the system, we were able to create a record for teaching, and then saving only the patient's unique identifier, recreate that record on many occasions and reuse it so that all the data would be in the same point in time and at the same point in the process of clinical care. So, for example, when the patient was used in 3 months after the first teaching session, the patient would be 3 months younger automatically, and the record would still be in the same instance of time when the students went in and looked at it. So we've had some success there. We've got a collaboration going with one of the commercial providers in the UK called System One, and they've set up a university sort of system for us where we can go in and enter template health records and copy from them and use them time and again for our education with our students. So lots of organisations use System One. There are lots and lots of patient records within the system. It's used across the UK in both hospitals and general practices, but also across the world. Some systems within Australia, for example, use System One. And Sarah's just put a screenshot in here just to show that we could create these acute hospitals and these acute simulated general practices and use these to populate, use these as centres to populate with our electronic simulated records and copy and reuse the data within. Now, I've already said that, Sarah's already said that we wanted to make sure that our teaching is system agnostic. So one thing we've been very keen to do is make sure that we don't train our students using one system alone. We're not here to train our students to use System One. We're here to make sure that they're able to cope with many systems that they'll encounter in their clinical work. So we've also managed to work collaboratively with another system provider, Patient Knows Best, and these are a really interesting company. This company actually provides the opportunity for patients to access their health record regardless of the commercial system that the doctors are using, and to be able to download it and access it as they wish on their smart device, whether that be a phone or an iPad or their computer. And again, this commercial provider has accommodated this idea that we'll be able to go in and we can now create simulated template patient records that are copyable and reusable. And because they're on a cloud server, they're distributable across anywhere where you have an internet link. So we've got an example patient there where we're going in and creating some data to support learning. Sarah.
Okay, so what were our next steps then? So we have the realization that actually it's really hard and time consuming for educators to create records. And as much as we had a working group of lots of universities, and the plan was that we would all kind of write a few and we would share these records, they are still very time consuming to create on the authentic record that we really want our students to be able to interact with. So really, from our next steps point of view, we felt that we needed to start to speak to people and actually have a plan for getting around exactly the authenticity of the record. So our next step really was to kind of speak to people about the purpose of why this work is important, why it's important to our patients as well, and really gaining insight from nationally. So Health Education England, for example, we have kind of digital education teams now for the NHS as well. So speaking to them and persuading people to get on board with the process, that actually the work that we want to do will be valuable nationally and internationally if we can really get a process in place that we can have an authentic record for our healthcare students in undergraduate education. We also really want to discuss the practicalities with people like we are today with you. So the technology and the delivery of content is not easy. There's been plenty of barriers in our way, including a pandemic, which has slowed down the process. The pedagogy as well. So how do we embed it into teaching and learning and assessment? So how can we really feasibly do this and help other universities to pick this up and run with it without it actually being too much of a problem to weave into curricula? And also to work with system suppliers. So we obviously have worked with TPP, we have System One currently on our computers at Birmingham and Manchester. But actually, do other providers want to also help out and come to the party and be willing to provide and simulate their version of the record for use for other, in education across the board? And we're not saying all universities needed to use R1, which is why we kind of wanted to speak to providers ongoing. So now we're in this really good position in that actually we're about to conduct some really important research into this process, because to have an authentic record, actually, we need probably a change in policy, which sits across the UK in terms of the way the data can be used. So Birmingham and Manchester now have academic clinical fellows that will be working on this project with us. What we want to be able to do is to actually use patient data. We want to speak to patients and ask them about their willingness to donate their data for educational purposes. So in the UK, data can be used for research, and data is automatically driven through that process for research for epidemiological studies, unless patients choose to opt out of that process. What that data can't be used for, though, is education, and it can't be used for education of our healthcare students. But actually, what we would really like is for that to be the case, is that we can use that patient data in medical education. So our first steps are going to be ascertaining the views of the public and patients about using de-identified versions of their record that would sit within our simulated patient record in the university setting, and to speak to them about what kind of information they're happy to have in there. Is there anything they would want redacted in that record as well? We would then also want to be seeking those views of healthcare professionals about what they think about that record being present within the university in a de-anonymised way as well. So in a de-identified way, the healthcare professional's name wouldn't be present, but their writings would be in terms of what they've added to the record. After that process, we actually want to go down the route of actually obtaining some patient records and some patient data for use in this project. So speaking to patients and consenting patients to donate that data so that we have maybe 4 or 5 whole records that we can use. And because our simulated record has the capability to rewind the date of birth and set it at a point in time, it does actually mean that one record can mean multiple patient representations for our students. Equally, it does also mean that the patient ages at the same rate. So we can rewind 5 years, for example, in a medical degree, or 4 years in a pharmacy degree, and that patient kind of becomes a year older throughout their degree, and we have that full history there. So we want to recruit GP practices and identify patients that are willing to match and donate their data to the record, and work with patients and the public on that process. We then want to be able to bring that into teaching. So bring that into our teaching sessions, implement it, integrate it, work with staff and students, and importantly, evaluate that teaching. We know there will be barriers to that process, and what we want to know is what they are. So for our staff, is this time consuming to implement? Can it be simply weaved into curriculum, or is it more complicated than that? Is there something that we haven't realised is a problem or a barrier? But also, what are the facilitators and the opportunities in that regard? And from the student perspective, what's their experience of that learning compared to paper? What competencies do they feel they can develop? And what competencies are they developing through assessment that we can prove have gained over time with access to that record? So there'll be some qualitative and quantitative work with students across the board at both universities when that's integrated. And our final step, of course, will be then to actually disseminate that to universities, because from a feasibility point of view, what we wanted this to be was a study that would create a framework for other universities that they could just pick up and run with, so that they can insert their own teaching scenarios and align these to the patients that are within the record, for example. You can see that the whole process is going to require a lot of working with governance, with NHS Digital, with our universities on board to support this, and patients and the public very much part of that process, because it's their data, and without them in this consent process of using their data, we can't create that authentic learning experience. So that's our next steps. We're currently, we've got an academic clinical fellow that started at Manchester, and we've got one due to start at Birmingham within the next few months. So watch this space.
Thanks, Sarah. So just to summarise then, I think hopefully we've shown you that we do feel that undergraduates need to work with EHRs, and they need to do this in a safe environment in order to develop competencies. This relies upon creation of authentic records, but this is a bit of a challenge, but real data can potentially address this challenge. EHRs for education need to be able to be used and reused again. So it's in direct sort of contrast to the situation we have in clinical care, where nothing is ever deleted or permanently changed. We want our systems for education to actually be able to allow that, so that we can go back to the same instance in care and help our students explore that, and then for that matter take another group of students through the same experience to help with their learning. And all of this will help with instance, comparative and longitudinal education. So students being able to think of what they would do in a certain situation, for groups of students or students within groups to compare what they would, their proposal and their actions with others. And longitudinal education, where you go back to a record, as Sarah said, at a later point within a course or courses, and revisit a story, a narrative, and perhaps even compare the effects of your intervention with those of others, either in your educational group or across professions in healthcare education. So I think that was the end of our conversation, our talk. Sarah, anything from the floor in terms of questions?
Yeah, so thank you, Sarah and Kurt. That was really informative. So yeah, if there's any questions that anyone has got from the floor about this project, or even comments or discussions about use of electronic healthcare records in undergraduate education, that would be greatly received. Hi, Abby.
Hiya, I'm Abby. I'm a teacher practitioner at Nottingham Uni and also a hospital pharmacist. Just had a question. How do you think this can be used going forward as prescribing's implemented? Is there any kind of electronic system that you have that you could use for students so that they can practice those skills as well?
So System 1 does allow prescribing. So System 1 is a fully integrated electronic health record with electronic prescribing modules within there. So prescribing can just happen as usual, as you would expect it to. And System 1 also has a hospital and a community kind of module as well. So you can allow them to contribute to that record and prescribe as usual.
Great.
And
I think we need it.
So Abby, also we have so we've got we're using both in Manchester now. So we're using you can use System 1, which is like a full electronic, well, it is a full electronic commercial health record, and that can have some benefits and some disadvantages, because as we said, we can look, there's lots of problems with things like information overload the first time they go into the record. There's clinical decision support, which you might or might not want. You might want alerts to pop up or not for your education. So we're also using Patient Knows Best now for the first time this year, our first teachings, and that is a system where there aren't those opportunities. It's students can just go in and add the medicines that they wish to, and it's quite a simplified system. So I think it depends on, there are these opportunities, and what you've got to think about is what tool would be best for the teaching you're trying to provide. And I'd say it's probably sort of a spectrum, really, because it depends on what your focus of that teaching is, and your group and stuff. But I agree, and we've used JAC as well, you might be familiar with. So they provide a similar system. We've used that a lot at Manchester for our electronic prescribing training at the medical school and the School of Pharmacy.
Great, thank you.
Okay, any further questions from the floor?
Anthony?
Hi.
Christine, yes.
Hi, Christine.
Hi, Christine Hirsch. I'm Senior Lecturer in Clinical Pharmacy at Birmingham. And I have to say, I came from the IPE, the Interprofessional Education stream interest group yesterday, and I think they would be so excited to hear about this as well. In terms of timing, the sort of potential for providing that route for students learning with, about, and from each other together with it through this, what's your estimated timescale? I appreciate that things take a long time to come to actual fruition, but what's your estimated timescale of being able to facilitate this for, say, an interprofessional education group?
So we're already doing it, Christine. If I just say we're doing it now, so we've started this term. We've already been doing it. for the last couple of years, but with a electronic prescribing system rather than a full EHR. So I think the problem we've encountered in Manchester is if you're going to use a full EHR and you don't want just a very skeletal, maybe a bit inauthentic, but simplified record, then that's when you have to start looking at patient data. So I think I'll let Sarah come back and talk about her experiences of doing stuff. Sorry, Sarah, but you know, I think it depends on what you're trying to do, really, Christine. If it's a sort of introduction, you might want something that's quite simple and basic, and it's quite easy to do that. And everyone can get that in the UK via TPP or Patient Knows Best, or some of the other companies I'm sure will be coming on board now as well. So, Sarah.
Yeah, so the four records that the four very short records that we created as a working group are present on TPP now and can be used now. So the TPP is available on all the computers in the whole of medical school in Birmingham. I guess the problem is that they currently probably don't reflect our teaching. So they weren't the records that we would use. For example, at Birmingham, we have a community called Woodbrook. That is a community of patients, and our plan was to try to match patient data, real patient data, to the comorbidities and the patients that we have within Woodbrook. However, having said that, there are still contributions to the record that you can make, even though it's a kind of a skeleton record without much history. There just wouldn't be a great deal of information gathering that can happen as part of that process.
I think the other thing to bear in mind,
sorry, carry on.
I was just going to say the other thing to bear in mind is that the next sort of paradigm shift, the next step change is that patients now own and easily access their data. So this Patient Knows Best is one example of several systems where patients can go in, can't they? And basically, myself as a patient, if I want my electronic record on my phone, I can have it, and I can decide what parts of that record I display to my friends, family, whatever I want. And so, you know, this is going to be another thing that we can do in terms of getting past this barrier of, you know, who owns data, or who owns the rights to access to that data, and how you get around that. So, you know, using something like Patient Knows Best or another patient-orientated and patient-owned system can really help our students gain access to authentic and real clinical data as part of their teaching.
If another school of pharmacy, medicine, nursing, or whatever wish to get involved in this or get hold of the software, how can they get involved?
Super welcome. Software-wise, it's well, for TPP, they've made that available to all health, higher education institutions. I'm sure they'd be interested, not just on a national basis, but they're an international company, so they'd be more than happy for that. It's just basically you just have to download their demonstration software, which is essentially a copy of their live software they use within the NHS, and then it's simply having an application on a desktop. That's the way that works. There's cloud space, so it's all the records and stuff are stored online in a cloud that they look after. PKB again, essentially they're very happy to let you have access to the system. So I think commercial providers in general will let you have a go at this. And the more we get involved, the better we'll have in terms of addressing this problem of making sure our students are system agnostic. We want them to experience different systems, and also greater buy-in from not just the commercial sector. I think they're pretty much there. I think it's more those that are looking after policy and the way that things go from an educational perspective. So
one of the first things with PKB, which is the Patient Knows Best, which is used quite a lot in the South, is that we can create records now with that. And one of the first thoughts from the point of view of Birmingham was around using that in our communication skills session. So having the patient, having that data and having a conversation with the pharmacist or the nurse or the doctor about their data. So approaching the community pharmacist to say, well, I've looked at my record and my blood test results show this, what does that mean? And having that data there to have that conversation, that's something that we can do straight away, because the PKB is relatively easy to populate, because it's a kind of partial record, really, in a summary record compared to a full electronic health record like System 1 is. And also working with PKB, they've already, obviously they use real patient data because it's real patient records, but they already have patients who are willing to allow their data to be used in education. and it's about the governance around that. So they're happy for us to start to use PKB with simulated records that we create ourselves, and then they're happy to work with us to push real patient data in, providing that we have the ethics and the governance in place to allow that to happen, and ensure that our students are kind of clued up with regards to the confidentiality and the processes around that information governance and security, really.
I think the step change with the PKB is that you could actually have, we're planning on having patients come along to teaching sessions, and they directly control what is viewable, because they are controlling the screen. They are literally, it is their record, it is on your phone. As long as they are making an informed choice and the consent, it's no different to them deciding to show their record to their friends or family or whatever. It's the same process. So I think that's something that could really change things when we look at more patient control, which is happening and has happened in terms of data. You've got this really amazing opportunity where we can have some really good conversations. For example, if for that week, for one of the weeks in our curriculum, we're looking at type 2 diabetes, it is going to be very easy to find patients with type 2 diabetes who would really like to share their experiences with students across professions and talk about their care. And as part of that, it would be looking at their record and having a think about what's documented and how that influences clinical reasoning and decision making and all the rest of it in conversation. So I think we are on the cusp of a very big potential change, if we wanted to, the way in which we recruit and use patients as champions, really, for education for our healthcare students, and definitely from an interprofessional perspective, this would be really, really interesting. So if you want to join up, if you're interested, please just drop us a line, and I'm sure Sarah and I can make sure you're, part of the collaboration. And yeah, we'd be delighted.
Thank you, Sarah and Kurt, for such an interesting presentation. And I think it's a really important area that we're going to have to grapple with very quickly. It's a relatively small turnout today, but I know that there are people who are very interested in this. So the session is being recorded. So, for example, Christine's IPE group, obviously they can watch this after the group. So it will have a wider impact than it may appear at the moment. So if you've got colleagues you think be interested in this, make sure you let them know that they can watch the recording of the presentation. Any further comments about the presentation? Oh, Claire.
Just to say thank you, that was really interesting and really useful. I'm not the person in Nottingham who'd be dealing with it, but I don't know why my colleagues aren't here, but hopefully they will be able to see it. I know Abby's here, so she will be infused about it as well, and Nadka, so thank you. That was really, really interesting. We might get you to come and speak to us in Nottingham, so watch this space.
Delighted to, yeah. I'd love to show some more of my data of how the electronic health will get away as well, because I think that's really interesting.
I love your videos and conversation. Allows this really powerful teaching tools. Just
really makes your students realise what you're talking about. Yeah.
Right, thank you, everyone. In terms of the rest of the meeting, we have, I think we'll probably be finishing a little early. This is a pharmacy discipline group. We normally have a bit of a chat amongst ourselves as a pharmacy discipline group about what we want to do with the group and etc. This should be my last year as the pharmacy discipline group lead, but I'm still waiting to see if anyone is interested in taking up the role. So if you are interested in representing the pharmacy discipline and the executive of the U21 health group, please get in contact. It's something that I think is important and something we could grow and hopefully go back to face-to-face meetings again. But yeah, it's an interesting group, and I think this is a really good example of something we could do together, perhaps as a U21 project as well. So
it's a great role. Just to jump in, Anthony, because I did it previously and I really recommend it. And it's great to interact with the other disciplines on the exec. You meet a lot of people who are really passionate about health professional education. So, and Anthony's done a great job for too long, so somebody else needs to take over. Not that you're not doing a good job, but you know what I mean. You need a break.
Yeah, I think it needs some fresh eyes to come in, and so do consider applying for that role if possible. Okay, any other comments about pharmacy discipline or this presentation? Otherwise, I think we'll come to an end. So once again, thank you very much, Kurt and Sarah, for excellent presentation about a really important subject. And in some ways, I think it would have benefited from being in the mainstream for the cross-disciplinary sort of side of the meeting, but it's still there for everyone to watch. So we'll make sure that gets out there.
Pleasure.
Thank you very much.
Thank you.
Thank you.
Bye.
Bye.
Bye all.
Thank you.